Hi, and welcome to an in-service on postpartum hemorrhage that was put together for the emergency department. My name is Donna Grothwall. I've worked at Elkhart General for 36 years and have an interest in teaching. I also work for Southwestern Michigan College with their nursing students in the OB department. So if you've seen my other video, you've already seen these things, but across the United States, the maternal mortality rate is being looked at, and especially in the state of Indiana. And you can see that the United States itself has a high mortality rate up to 26.4 back in 2015. And you can also see other countries, other developed countries, have decreased their maternal mortality quite a bit since 1990. In Indiana, in this map, you can see the three states that are darker in red, and this is not a color that you want to be, but we are the third state with the highest maternal death rate. We're behind Georgia and Louisiana. And if you look clear to the left, you'll see that California and Nevada are in the light pink, which means they have the lowest death rate in the United States. If you just look at Indiana, you can see that Indiana, compared to the United States as a whole, we have a maternal mortality rate back in 2016 of over 40 women per 100,000 live births. And you can see that United States together is down just over 20. So we probably are about twice as high on our mortality rate than the rest of the states put together. So this last graph that I'll show you compares California to the entire United States. California is in blue, and they had a spike in their mortality rate back in 2006 and went up to 16.9. It was recognized as a problem. It probably started with a small group of people and gradually got larger. Stanford University got involved with it. Anesthesiologists got involved with it. And so protocols were defined. And, they're very specific when somebody needs to be called, when you need to get consults, what tests needs to be done, what x-rays or MRIs or CT scans need to be done, and in what kind of time frame. And as you can see, this graph got cut off a little bit, but by 2013 they were able to bring their rate down to 7.3, and that was a 55% change from 2006 to 2013. So this collaboration became known as the California Maternal Quality Care Collaboration, shortened to CMQCC. And they have put out their protocols. We don't have to pay for them, but it's a way for us to try and decrease rates in not only Indiana but across the country. So if you're interested, their website is cmqcc.org, and they do have some information in there for emergency departments also. And it's not just hypertension or postpartum hemorrhage. There's various things that are in there. So postpartum hemorrhage is the leading cause of mortality worldwide, and the next two are infections and hypertensive disorders. 10% of women suffer some degree of postpartum hemorrhage. So the body itself physiologically is quite fascinating in how it's designed to help. Some things are designed to help protect the woman. So the woman has about a 40 to 50% increase in their plasma volume. That increases their RBCs, approximately 25%. And the body can lose this extra plasma volume and not really show much of a change. Uterine bleeding after birth is controlled by the contraction of the myometrium of the uterus, and what it does is it constricts those blood vessels that were supplying the placenta. So about 10 to 15 minutes in a good situation, the placenta is delivered, and it leaves lots of big open vessels at that point. So the uterus will contract in an effort to constrict those blood vessels so that they don't bleed too much. Acute anemia interferes with oxygen delivery to the tissues, and subsequently then they have vasodilation of those vascular beds to bring more blood to the area. So, we don't want more blood in the uterus. So if we can get that to clamp down, then we're in better shape. So in the long run, with with a huge hemorrhage, the tissue hypoxia will result in anaerobic metabolism. It'll produce lactate, which results in lactic acidosis, which destroys cells. So what is the definition of a hemorrhage? Per ACOG, which is the American College of Obstetricians and Gynecologists, they define it as a postpartum hemorrhage cumulatively of greater than 999 cc's. So once we hit 1,000 cc's, then it can be called a hemorrhage. Some books you'll read that it's over 500 with a vaginal delivery, over 1,000 with a C-section. But in this last box at the end, then when we hit 500 cc's, then it tells us that we need to keep a closer eye on this individual and be ready to intervene if necessary. Another definition of hemorrhage is blood loss accompanied by signs and symptoms of hypovolemia within the first 24 hours following the birth process. So there are different factors that can cause bleeding, and you can see that there's an early or primary hemorrhage, which occurs the first 24 hours after delivery. And then there's also late or secondary hemorrhages that occur greater than 24 hours and can happen up to 6 weeks postpartum. Our greatest risk is that first hour after delivery. And 80% of women who have an early hemorrhage, it will be due to uterine atony, where the uterus is not contracting and is very boggy, and those vessels in the uterus where the placenta they're just bleeding. It also could be from retained placental fragments. If there's placenta that's left in the uterus can't contract as efficiently. Placenta accreta is a placenta that abnormally adheres to the uterus, and there's placenta accreta, percreta, and increta, and with each one it progressively gets embedded even farther. And a lot of times we know that this is the case from earlier ultrasounds, but if the patient hasn't had any prenatal care or had prenatal care at another hospital and we're not aware of it, then you really don't know until you've been trying to deliver the placenta for a while. If we know they're going to have one, then we are prepared with blood products. Their surgery might actually, if they may have a planned C-section in the main OR, and they'll also have other surgeons in the room because these patients can end up having to have a hysterectomy with a great blood loss. They may have defects in their coagulation factors. Uterine inversion, you can actually pull the uterus inside out and it'll come out through the vagina. I've never seen one personally. I know we've had them, and this can cause a great deal of bleeding. And reasons why this happen is sometimes there's too much traction being placed on the cord, which is attached to the placenta. It could be a short cord. There's reasons why that can happen, but imagine, doing a fundal exam on a patient, and as you push on it, the whole uterus actually turns inside out and comes out. This is another reason why it's important to put your hand at the top of the uterus and also support it at the bottom, because that will, especially when we're doing more of a massage, then there's a higher chance. There could be hematomas in the genital tract, and they look like hematomas just inside. They're very firm and are very uncomfortable for the patient. The late or secondary factors are usually has something to do with a uterine infection. Again, the uterus is not contracting as it should. There may be some retained placenta and more coagulation defects. If you have a firm uterus and you're still having a lot of bleeding, it's probably from laceration or something like that inside that needs some repair. Risks for postpartum hemorrhage, there's many. And if they've had a prior postpartum hemorrhage or a close family member, mother, sister, with a postpartum hemorrhage, that puts them at higher risk. The trauma of delivery, some deliveries are much more traumatic than others if they have lacerations or hematomas. Fibroids, if they've had a very fast labor and delivery, a prolonged labor, their uterus just kind of gets tired and it just doesn't want to contract. I'll move farther ahead. An operative vaginal birth would be forceps or suction. Uterine over distension, like if they've got twins or triplets or more, then they're really much more of a high risk because, again, that uterus has been stretched out for so long that it just doesn't want to contract. Uteruses can rupture under certain circumstances, and that can cause a lot of bleeding if they have a fetal demise, lower platelets, if they've been on oxytocin or pitocin for a good amount of time, or if they've been on mag sulfate during their labor. The magnesium will cause the uterus. It's a smooth muscle relaxer, so it can affect the uterus also. But more than 50% of women with uterine atony have no risk factors at all. So it can happen, and we don't really know why. We do part of our protocol is to do postpartum. We have a table that we go by, and we do postpartum risk assessments upon admission, soon before delivery, after delivery in that first hour, and then we do them every shift after that. So how do we measure the quantity of blood loss? We used to do estimated blood losses where the physician would just take a peek at, sponges or, blood on the floor, that kind of thing. But they have found that estimated blood losses are grossly are understated. So now we do actually the quantity of blood loss by actually measuring it. So especially when we're having more bleeding, we have a scale we bring in. We know how much sponges weigh, how much peri-pads weigh, chucks weigh, those kind of things. And so we'll actually measure and keep track of that so that we know exactly where they're at. And just as an FYI, blood loss, for every 500 cc's of blood loss, they estimate it's about a 3% drop in hematocrit and a 1 to 1.5 gram drop in their hemoglobin. But again, you can't always trust that. And the reason why you can't always trust your hemoglobin and hematocrit is because we're usually giving lots of fluids during this time. So if they've received lots of fluids, it's good to wait and hold on to do that first hemoglobin. Now, if they're bleeding profusely, that's one thing, but we're going to wait an hour or two before we do our next H&H because it's probably not going to be real accurate. The hematocrit's going to be high, and the hemoglobin actually won't drop as quickly as as you think it might. Oh, this is another uh, so this is another slide that just addresses the quantified blood loss. We do have a postpartum hemorrhage chart, and in it is our scale, pictures of the sponges or whatever and how much they weigh, and 1 gram of measurement equals 1 ml. So if we've measured 500 grams so far, then they've lost 500 cc's. So this protocol here just it puts them into stages, and the first line, which I know is hard to read, is stage 0. This is where they haven't lost a lot of blood at this point, but we do have the hemorrhage cart outside their door. Stage 1 then, though, is a blood loss between 500 and 1,000 cc's, or they're having symptoms that are recognized as with someone who has blood loss. And it'll tell you who to notify, gives us other things that we need to do. We're going to increase IV fluids, give more Pitocin, we're going to do fundal massage, and we might give some other medications that we'll talk about here soon. Probably want a type and cross done, and then think, is it a uterine atony, is it lacerations, or so forth. Stage 2 would be bleeding loss under 1,500, so between 1,000 and 1,500. At this point, we're probably going to get a second IV in. We're going to be given some other meds if we haven't already. The doctors sometimes put in a Bakri, which is a balloon tamponade. It goes into the uterus, and then it's filled up with water, and it just puts pressure on all those vessels. So we're probably going to be giving some blood at this point, Stage 3 is over 1,500 cc blood loss, and this is where things are getting bad, and we need to do a mass transfusion. And the doctors will be thinking about what procedure they need to do next, but they may be getting FFP, platelets, cryoprecipitates. There's a lot going on with them at this point. Signs and symptoms of hypovolemia. I know I don't need to go through these. I guess the only thing I want to point out is that hypotension, dizziness, pallor, and oliguria usually don't occur until the patient's lost between 10 and 30% of their total blood volume. So keep an eye on that blood pressure and heart rate, but we may not see changes in that until we get farther down the line. One other thing we can check is called what it is, the mean arterial pressure. But I have the formula there, and we can figure out what their MAP is. And one of the first BP responses to hypovolemia may be a pulse pressure that's decreased to 30 or less. So that's another tool. Then we get into some of the excessive bleeding symptoms. So maternal early warning signs, or MEWS, are another thing that we're keeping an eye on. So as soon as we have a blood pressure under 90, or heart rate over 120, respiratory rate less than 10 or greater than 30, or any of these things, we are going to repeat those tests within 10 to 15 minutes. And then if they're still low or high, then we're going to be notifying the physician. If we have, oliguria for 2 hours, the mom is getting agitated, confused, or unresponsive, or if they have hypertension, we'll notify them of headaches. Those need to be done immediately. So our pharmacy management of postpartum hemorrhage are several different drugs here. Oxytocin or Pitocin is the first drug we're going to give. We already give some right after the delivery of the placenta. It's a natural hormone in the body, but we give a synthetic version of that. We use it to induce labor in very, very small amounts, but then after delivery, we're not worried about the uterus rupturing, so we can give larger amounts in a faster amount of time after delivery. And this is a high alert medication, but it's more of a high alert med when the patient's still pregnant. The second drug we might use is Methergin. This affects the smooth muscle of the uterus. It's always given IM. It can be given in other ways. You can give it IV, but you run a real high risk of hypertension or stroke. So, and patients who are already hypertensive can't have this drug because it does increase their blood pressure even more. So this med we give IM. Another drug would be Cytotec, which is a prostaglandin that also causes uterine contractions. We use it also as a cervical ripening agent. If we have a patient who's in for an induction and their cervix is still pretty thick, but they need to be delivered, then we put like a quarter, it's about 25 milligrams or micrograms of this drug up by their cervix, and it helps to start thin it out. But after delivery, we give it again in much greater doses. It can be given PO, but most often it's given rectally by the physician, and we can give up to 1,000 milligrams of that. It is a teratogen, and so we have to be very careful not to touch it, especially ladies who are pregnant shouldn't be touching it. So we do put a sign on the door stating that the patient has received Cytotec, and for the next 24 hours then people taking care of them have to wear gloves. Another drug would be the Hemabate, and it's also a prostaglandin. It's given IM, and sometimes the physicians just inject it right into the uterus, and it stimulates those contractions, and it helps to provide some hemostasis at the site of where the placenta was. It also stimulates the smooth muscle of the GI tract and can cause vomiting and or diarrhea, so we sometimes have to give meds for those two things too. And then the last one is the tranexamic acid, or TXA. This drug has been used in other countries for quite a while, but it's just become more of a standard in the hospital in the last couple of years. And what this drug does is it's actually not working to decrease the bleeding, but it is hoping to, I guess it does help to reduce the bleeding because it inhibits the breakdown of fibrin blood clots. And with the more hemorrhage you have, the higher your risk of coagulopathy is. So we can give a dose of this. It's given IV, and the first gram can be given over 10 minutes, but the pharmacy does mix that for us, and we just put it up and pretty much run it in over 10 to 15 minutes. And this drug can be repeated one time 30 minutes later if needed. This drug is going to be the last thing we're going to give. The other drugs are more important to start giving before you get to the tranexamic acid. I'm still not saying that right. So excessive bleeding would be saturating the peripad in 15 minutes or less. And so these patients need continued fundal massage, and you can see there's kind of a picture there for you to look at where the hands, there's one on the top of the fundus, which on the left side of the picture, and then there's the other hand is supporting the bottom of the uterus in an effort to not push it out. But and we want to give a decent massage, but not excessively, because excessive massage can tire the muscle fibers, and then we're going to have the opposite effect that we want. Bright red blood with a firm uterus can be a sign of lacerations or the episiotomy bleeding. Sometimes they just have some big old clots in there that need to be pushed out. And if a patient needs to void, that will also deviate the uterus a bit. The uterus is usually right, depending on what day they are postpartum, is midline at the umbilicus or below. You can see on the different days. By day 7 and 14, it's almost impossible to feel the uterus unless you've felt a lot of them at that point. But if their uterus is deviated to the right or it's above the umbilicus, then they probably need to void. And the best thing to do at this point is to put in a Foley catheter. Other treatment includes putting the head of the bed down. You guys know the tricks for when somebody's bleeding out. We're going to run IV fluids. We're going to increase those. We need a second IV start at times. We want blood pressures at least every 15 minutes, SaO2 monitoring, and heart monitoring. Patient's going to be cold, so warm blankets. We need a very accurate INO. They may need pain management because we're pushing on their belly a lot, and they need lots of emotional support, the patient and whoever's with her. Talked about the Bakri already. That would be something we have on our unit, and we keep that in our hemorrhage cart that we could bring. And then there's some syringes that we need to fill up with sterile water. The usual labs that need to be done when somebody's bleeding, and then we need to be prepared to give the packed cells, platelets, cryoprecipitate, or the FFP. And somebody needs to be writing all this stuff down. They may, what's going to happen at this point is they may have to go to the OR for a DNC. If they were a section and they think the bleeding's in the abdomen, then that they may need to go in and have that reopened. Sometimes these patients end up needing a hysterectomy, and they try everything they can before they get to that point. And one thing we're doing more and more of is sending the patient to interventional radiology, and they will embolize some of those arteries. This slide I found interesting, and it's probably just because I don't give a whole lot of blood, but these are the different units of blood, whether it's packed cells, platelets, and how by giving a unit of packed cells, we hope to increase the hematocrit by 3 percentage points and the hemoglobin by 1 gram. Of course, if they're bleeding more blood out at the same time, that's not going to happen. And so on. That 50 ml of platelets can be expected to increase the platelet count by 5,000 to 10,000, and so on. So that's probably something you guys already know, but I just found it interesting when I came upon it. And the last statement there talks about the ratio of packed cells to the FFP and platelets that are given. So that's the end of my presentation. Thank you so much for taking the time to watch it. If you have any questions at all, please feel free to let me know. And again, if there's anything that we can do to help you, if you have somebody bleeding and you need some extra hands or somebody to go through the protocols with you, please come the maternity charge, and we will do our best to help you. Thanks again.